You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael, Chief Medical Officer of the International Myeloma Foundation and Professor at TGen City of Hope Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Joseph Mikhael, and welcome to Medscape In Discussion Multiple Myeloma. Today, we're talking about addressing comorbidities in multiple myeloma. I picked this topic because it's so critical in the field of oncology in general, but in particular in multiple myeloma, where over half of our patients are 70 years and older. And frankly, historically, as myeloma treaters, we haven't been ideal in fully assessing our patients and understanding their needs, their comorbidities, and then appropriately responding exactly as how to manage their treatment. In fact, very often we've thought of it as just deciding, is this patient transplant eligible, yes or no? And as we're going to hear today, it's a lot more than just that. And if we're going to give ideal care to our patients, we need to understand this topic much more fully. It is absolutely my pleasure to join not only a world expert in myeloma and oncogeriatrics, but a very good friend of mine, Dr. Ashley Rosko, with us today. She is an associate professor in the Division of Hematology, and she's the medical director of oncogeriatrics at The Ohio State University. So welcome, Ashley. It's really great to see you.
Thank you, Joe. I'm very pleased to be here today.
So let me just kick us off, Ashley, with a case that may at least trigger some of the discussion. So a 71-year-old woman who has diabetes, hypertension, and had a myocardial infarction 4 years ago was just diagnosed with multiple myeloma. And the community oncologist is wrestling with whether or not this person should go to transplant or not. In my introduction, I noted that historically it's really just been, a flow chart that has two options. Are you to transplant or not to transplant? That is the question. And hopefully one of the key lessons today is that isn't the only question. That's one of many questions. But nonetheless, that's what's happening in this case. So why don't I turn it to you and say, what is sort of your initial approach to this, instead of just trying to, in the classic old days of clear them for surgery, doc, clear them for transplant, Dr. Rosko. What are you going to do with this patient to better understand their fitness and frailty going forward?
Absolutely. So I think this case illustrates the majority of patients who are coming to our clinic diagnosed with multiple myeloma. The average age of a patient diagnosed with multiple myeloma is 70 years of age. And when you think about comorbidities, more than half of our patients diagnosed with multiple myeloma have at least one comorbidity. But it is increasingly common to see many comorbidities, and understanding the severity of those comorbidities plays a good role. We're very good at understanding what medical conditions they have. But I think importantly, being able to characterize treatment strategies, whether that's transplant or non-transplant. And I'll just take a moment to mention, very pleased that the field of myeloma is moving away from that stratification, moving away from upfront, deciding whether a person is eligible or ineligible for therapies. I think our clinical trials are moving that way. And as a field, we're moving away from this kind of upfront stratification. But then it gets back to that question about, so when someone is coming into your clinic and there are multiplying therapies for patients newly diagnosed with myeloma, and how do you design treatments for those patients? And we have, in myeloma specifically in the field, a lot of work has been done in this area to be able to characterize frailty. So frailty is a term that is used more frequently than it is defined. We have many scales that have been validated in the field to be able to identify risk of morbidity, risk of mortality, risk of treatment or drug discontinuation. And so these scales can help guide us to estimate what the patient's underlying health status is. And so I'll take a moment just to review some of the scales that have probably been most rigorously defined, not to say that because the scales that we have available, each one has its own barriers to use. Each scale has its own deficits, but at least we are talking more about moving away from chronologic age alone and really getting to the sense that this underlying health status or fitness on one end or frailty is really a way for us to be able to better estimate patients' health better estimate treatment tolerance, and better estimate transplant eligibility. And so those scales are things like the International Myeloma Working Group Frailty Scores, the Revised Myeloma Comorbidity Index, or even the Simplified Frailty Scale. Each of these scales moves beyond chronologic age alone and adds additional health factors that can better estimate treatment tolerance.
So can I interrupt for just a quick sec on that notion? Because I think that is something that historically we've always used as kind of the key barrier or the key factor was just the age of the patient. And I'm very encouraged to see that we're moving beyond that. Even just a couple of years ago, we published the first ASCO guidelines in myeloma, and we said age alone should not be what is defining a patient's transplant eligibility or even treatment eligibility. So I just wanted to emphasize that point as you're going through, because historically, a geriatric assessment, as it were, is just looking at the date of birth, right? And clearly, the date of birth means something, if I'm hearing you correctly, but it's clearly not everything. And so these scales that you're about to describe are taking us beyond that single date.
To your point in that sentiment, there probably are still many questions where people ask or query, what's your upper age cutoff for a transplant? And we don't have one. We don't have one at our institution as part of our guidelines. I think many institutions are moving away from age-based or upper age-based transplant eligibility because for those very sentiments that, you can't tell me that there's a biologic difference between someone who's 70 or 71. And really getting a good sense of what is going on to that patient's health. And importantly, I think this is where things get really important to be able to understand for patients with multiple myeloma. Health status is dynamic, and a new diagnosis of multiple myeloma can significantly impact your underlying health status, whether that's your function because of a pain related to myeloma bone disease, whether it's related to being, fatigued and tired due to anemia, and just having a new diagnosis of cancer. And across our studies, there's not a study that's not been published. When you treat a patient newly diagnosed with multiple myeloma, their performance status will improve because of health-related quality of life tracks with disease control. And if you can get disease control, so knowing where you start may not be where you end, and understanding that this dynamic process, it's really the definition of frailty, is that it is dynamic. It does change with the time of diagnosis. It does change with therapy. And so I think to that, sentiment of saying it's not age-based, but also understanding that as someone's diagnosed with myeloma and gets better disease control, their functional status can significantly improve.
That's really, really helpful. So let's talk a bit more about these tools, these scales, because, there's so many of them, of course, and a lot of people say, look, can you just simplify it for me? Is there a 3-second bedside test that I can just, wave some magic pixie dust and I'm going to know what the comorbidities are and the frailty index of this patient? I know that's impossible, of course, but tell us how you use it in your clinic. What would be the best tool for our community oncologists and myeloma treaters listening to this? What would be the best thing for them?
I also don't think it's so far off. I do think that there are ways that we are doing this in practice, but we can operationalize it further. For example, so the International Myeloma Working Group scale looks at things such as age, activities of daily living, instrumental activities of daily living, and comorbidities. But in the real world, how we break that down is what are you able to do at home? Are you doing the grocery shopping? Are you able to cook meals? And that can give you a good sense of their IADLs, right? So those are things that you're asking when a patient is coming into your clinic anyways. One of the important things that I, do in focusing on aging adults with multiple myeloma, not so much to ask about what activities they are doing, but also importantly to ask what have they stopped doing. Right. So it makes a big difference if someone is, doing all of their activities of daily living, but previously used to run 3 miles a day and have stopped doing that and can't do that any longer. Right. So that's a bigger difference, in terms of being able to get about your house versus stop doing much more physical, intense activity. So I think asking what patients are doing in terms of activity and also asking what they stopped are things to be able to gauge their underlying health status and is in alignment with those type of frailty score calculators. The revised myeloma comorbidity index is a little bit more detailed. It takes in things like age and performance status, but also incorporates what we would consider the gold standard for frailty assessment, which is the Fried's frailty phenotype. Definitely those type of scales, I would say, are more research centric and are not necessarily things that are routinely employed in a routine clinic. But it's also asking a sense of what their underlying function is more objectively. So asking things about the ability to get up and walk and timing that and getting objective measures of health, I think is a great place to see where the field is going. There are many more scores, there are many more calculators, but I think importantly, the idea of characterizing fitness or frailty using a tool is better than using age alone. We have much more robust measures to do that using things such as a comprehensive geriatric assessment, where we really go through the domains of underlying health status and can do that in concert with routine oncology care.
That's fantastic. So I'm learning a lot here today. So I think one of the key things you're sharing with us is I like this idea of asking both what they can do and what perhaps they've stopped doing. And then to close the loop on these tools before we move on to thinking about specific comorbidities of interest, I think it's important for us to think a little bit about together, what does this mean at the end of the day? Like, what's the point here? And historically, it's always been, are you transplant eligible or not? It's really been that simple pathway. And I think from what I'm hearing from you and from what I know and I've seen you work on and published, if I understand it correctly, it's really not just that, although that's part of it, but it's also deciding what is the best regimen for patients, what is the best dosing within that regimen of patients, and then having this kind of ongoing assessment once you've established that baseline, so that as we go through, we can make adjustments so that patients can remain on therapy and have an ongoing assessment of their quality of life, so that we're not so impairing it that they're ultimately just going to discontinue therapy. So I know I may be putting words in your mouth, but is that the end game here? It's not just to transplant or not, it's also to assess what is the best regimen, what's the dosing of that regimen, and then the ongoing follow-up through that regimen.
Joe, I think that your point there, talking about right-sizing therapy for patients and in making sure that patients are able to receive and continue on treatment is really the goal, right? So if you provide someone with a very intensive regimen up front, and because they're already sick related to their multiple myeloma diagnosis, and then you're intensifying their therapy, it's a mismatch. And then therapy is held, therapy is discontinued, and you have these big, long treatment breaks, I think that really does a disadvantage to an aging adult with myeloma. And so right-sizing therapy and this being able to maintain patients on the therapy that they need, I think is really pivotal.
Well, let's think about a few comorbidities that I know have particular interest. And I'd like to focus on two of them in particular, neuropathy and cardiovascular issues, because I know those come up so much.
Yeah, I mean, I think so, and we talk about neuropathy and we talk about cardiovascular disease because especially in a patient who is newly diagnosed with myeloma, we have that chance, that window to not prevent problems, right? So I think this kind of preventative approach, when someone comes in and you already see that they have diabetes, run several neuropathic agents, that's an opportunity for us to say, let's not make things worse for you, right? So if someone has pre-existing neuropathic conditions, we have options, right? We have studies of, that, for example, like even in the endurance study, looking at, frontline VRD to frontline KRD, differences for patients who are standard risk. But at the same time, there are certainly gives you options to say, well, if someone comes in and we know, even in those studies, that there was more neuropathy in a bortezomib-based group, then we have an opportunity to say, well, let's try to use an alternative agent with less neuropathic symptoms to not exacerbate someone who already has a pre-existing condition. So those are the cases where, you'll say, well, there's data to say that this one's better than that. But if you're harming someone and causing more neuropathic symptoms, falls, immobility, or just, a decline in their function, then you're not necessarily helping them. So I think that type of preventative approach when it comes to neuropathic agents, I think we're, well-tuned and well-engaged to be able to quickly, come off of doing once, from twice a week therapy to once a week therapy. And Joe, I'm curious to know your opinion a bit about this. What is your thoughts about for patients with, once weekly versus twice weekly in someone who's otherwise fit?
Yeah, I generally always use bortezomib subcutaneously weekly. Both of those strategies reduce the neuropathy, even reduce the thrombocytopenia. Very rarely, even just for the first cycle, I give it twice weekly. As you said, if someone has very intense active disease and we want to try and bring it down, especially in the context of renal insufficiency. The other point I'd like to make here is that how important it is to have that ongoing assessment, because at the first sign, even grade 1 neuropathy, I think it's critical to intervene, typically by reducing the frequency of the agent and maybe having to discontinue it. We never want our patients to go down a one-way street of neuropathy. But with regards to cardiovascular issues, what are your insights there?
Yeah, I think importantly, when we're thinking about the same type of idea, when we're looking at drugs that include carfilzomib, these kind of composite measures in many of the studies looking at cardiac impairment, shortness of breath, hypertension, we see this, more commonly in patients who have carfilzomib. So I think one being, if someone has active cardiovascular disease or have had a recent cardiac event, then I would be more thoughtful about, using that agent. But for someone with well-controlled, who has a history of coronary artery disease, remote history, like this patient, how you describe here, of having an MI, it doesn't necessarily preclude me from using that drug. And I think that's important to know. And so some people ask about, do you do baseline echoes if you're worried about, I'm like, I'm definitely much more in tune to the symptoms related, to carfilzomib, such as shortness of breath or the new development of high blood pressure. But I don't want to preclude a drug that is, very effective for patients in the relapse setting or, in many cases in the frontline setting too. So I think I want to be clear about that, is that saying that I'm thoughtful about those toxicities, but it doesn't necessarily mean I don't use that drug.
Yeah, I'm completely with you there. And I've written a little bit on this. I can think of the only situation where tomorrow I wouldn't give carfilzomib to a patient would be if they have, at that very moment, uncontrolled hypertension or uncontrolled heart failure. And what I would do is just delay it, not necessarily discontinue it, but delay it until that was under better control. Well, I have to take advantage of the fact in our last few minutes here that I have the medical director of oncogeriatrics from the Ohio State University. And I want to ask you, Ashley, there are so many aging issues that can influence us. Sometimes as hematologists or oncologists, we become very focused on, I always say, I don't treat myeloma, I treat people, but sometimes we can get so focused on the plasma cell, we kind of lose the rest of it, other issues that are happening around polypharmacy or other things. And I just wonder if you have some pearls for our audience today around this.
Yeah, absolutely. So, here, so I think one of the challenges in treating aging adults is that needing this additional expertise. And many institutions have the ability to partner very closely with geriatricians in their field or geriatric oncologists, or a much needed necessity. But here at Ohio State, I think necessity is the mother of invention. And one of the things that we really needed was to be able to not only help older adults with multiple myeloma, but really older adults with cancer as a whole. And so as such, one of the things that we created was a multidisciplinary clinic specifically for aging adults, which really unites allied health professionals to do a comprehensive geriatric assessment as the standard of care. So as you know, many key stakeholders and leading agencies have recommended that all patients 65 years and old diagnosed with cancer undergo a geriatric assessment, which is a comprehensive, in-depth evaluation of a patient's health status with a concerted plan for that patient. And so I created and developed a clinic for older adults of having health professionals such as a pharmacist, a nurse who's trained to do an in-depth cognitive assessment, physical therapists, case managers, an audiologist, and really together we work in concert to be able to address the needs of aging adults with cancer.
That's fantastic. I commend you on that. And I know we're going to learn a lot from you and from what the outcomes of that clinic are. So before we wrap up, Ashley, what's one thing you want to pass on to the listeners that might be useful?
Myeloma is a disease of aging adults, and really, shifting away from age-based decisions is really important. And I think, thinking comprehensively about your patient and being able to start a myeloma therapy and understanding that frailty is dynamic, and reassessing a patient at the time of their diagnosis and throughout their treatment course would really improve treatment tolerance and health-related quality of life.
Well, you've heard it from one of the world experts in the field, Dr. Ashley Rosko. Thank you so much for joining me today. There have been so much to take out of this, that age alone clearly is not enough as we address comorbidities in our patients and recognize how common these comorbidities are, how they dynamically change even with response to their therapy, and how there are validated tools and validated models, as we've heard of this clinic, that can really help patients along. As I mentioned earlier, we don't treat myeloma, we treat people. And it's so critical that we capture this as we go through. So thank you again for your time with us today, Dr. Rosko. Thank you for our listeners. And we trust this is helpful to you as you care for your patients.
Thank you.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple myeloma.